every time you give someone pain medicine, you need to tell them, I'm giving you some pain medicine, and it should start working. In about half an hour, you should start feeling a whole lot better. And that will make that happen. It's the placebo effect in action, which is not meaning it's anything wrong with it. The placebo effect is a very powerful tool that we can use to our benefit. And don't give someone pain medicine without telling them, because then it won't work as well. If you just give it to them, I mean, unless they're asleep or something. But if you just give it to them and you don't tell them, then it won't work as well. So you're wasting some of the medicine, basically. So effective pain medicine management, which is not always medicine, also improves quality of life. And here we're mainly thinking about like chronic pain management, but not always. Reducing disability, certainly with chronic pain, yes, well-managed chronic pain. If it's managed, people are able to continue working as opposed to going on disability. But also, if you think about, there's a lot of information out now about children, infants and children that are exposed to repeated acute pain procedures, like they have some kind of medical problem or they have to have lots of surgeries when they're little. And if their pain is not well managed, they have permanent physical, mental, and emotional problems that persist through their life. And we're seeing these kids in pain clinics with chronic regional pain syndrome that have to get blocks every 2 weeks. They have to get a regional anesthesia block just to stop this horrible, unremitting pain that has no physical cause that we can determine. Or they have learning disabilities, they have emotional ability and handicaps, depression, anxiety, things like that. They're very sensitive to pain in general, so we've lowered their pain pressure. So kind of, big deal, like get on it early, especially with little kids and stuff. But it's not so good for big people either. Certainly we talked about getting people early ambulation after surgery and preventing all those complications. Well, guess what's going to get them up? Control their pain. They're not going to get up and ambulate if they're hurting too much. So they're going to get the DVTs, the bed sores, the urinary retention, the constipation, all those things and the pneumonia. So if we get them pain management, they get up, they move, they don't have those things, they don't stay in the hospital as long, doesn't cost as much, they're happier, they send back a big smiley face on their patient satisfaction survey and you get a raise. So that's good. That's what we want. We know that pain has physical, definitely there's a physical component. There's also some emotional and cognitive parts of pain that can affect how it's perceived and acted on. And it's a completely subjective experience, which makes it difficult for some people to assess and figure out what to do because there's not a number, there's not a hard answer there. And sometimes people can't tell you what the answer is, they don't figure it out. But as a review, you should remember that there's several phases of pain transmission through the body. Transduction is the actual, you put your finger on the stove and the little fiber in your finger gets stimulated and goes and sends an electrical signal up your body. Transmission via the A fibers usually first, and then the C fibers get involved. The A fibers give you that sharp sensation like, ow, that's hot. And then the C fibers kick in, and your whole finger starts throbbing. If you've ever burned your finger or something, kind of that general, ouch, that whole body hurts. So in order to have that whole sequence, and especially the part where you pull your hand away, you have to have the brain and the spinal cord all working and stuff like that. So again, the perception part, once the brain gets that impulse up the nerve pathway, it has to interpret it and perceive that as pain. And that is pretty much hardwired into you to perceive something as pain. So it's not that X person doesn't feel pain when you poke them. It's more that some people feel pain when you do anything because they've got big pathways. And the way that I can best describe it, and the way that research is showing this happens, is that we know, remember when you learned about the brain in AMP and probably in patho, they talked about, neurons and the connections, and the more these connections were used, the stronger they got, and the more permanent they were. It's kind of the same thing with any other you have this source of pain and it's constantly sending signals to the brain up here, this pathway is pretty soon going to be an 8-lane freeway. Any stimulation that comes in here is going to go shooting up that pathway because it's the biggest thing there. So then pain is going to be perceived really with almost any stimulation.
So would that be the opposite then with things like meditation and ways to control your perception of pain?
That's how we think that it might work. That's not very well understood as far as I understand. But we know that people that have repeated or constant stimulus are much more sensitive to other things. Like cold can feel like pain. Something else can be interpreted as, anything practically in the area can be interpreted that way. So it's one of the things that we want to try to nip in the bud. Because we don't really want to make superhighways in people's nerve pathways of pain. So when we say that people may not perceive pain in the same way, it really doesn't mean like this person doesn't feel pain at all. That's just pain threshold thing. That's a genetic thing. Some people don't, but not really.
Does what you're talking about, like creating an 8-lane highway, is that more modulation or more perception?
That's more like the transmission. Actually, you actually do strengthen the neural connection is strengthened. The nerve gets bigger and stronger connection, and then the perception is also more. This is pain. This hurts. This hurts. So you get more and more signals saying this is hurting. This is hurting, and pretty soon that's all that your brain hears. And you can certainly get these sensations even without any stimulus. Think about an amputee with phantom limb pain. They don't have anything poking their leg. Their leg ain't there. Their leg's been burned up in the incinerator. But they still feel it, so we know that it's not necessarily coming from the place where it's coming, where it feels like it's coming, it's in the nerves. It's the nerves in the brain that are doing this, probably. And so it's something in the brain we need to adjust, which is why probably things like meditation might help, because that affects your brain chemistry. So part of perception is what you perceive as pain, and part of it is what the context is, what your knowledge is. If you've had this before and you know that it'll go away, you stub your toe, you're like, oh man, that hurts. You jump around, but you know it's going to go away in like 2 minutes. On the other hand, if you've broken, you've torn an ACLs or something like that, and then you do it again, and you're like, oh man, that's going to be 6 months, or whatever you've had your experience, that's like a bigger deal sometimes. The context can be really bad. If it's something that you knew you've had before, it's happening again, you're going to have to drop out of school, that's going to impair your perception a lot. It's going to make it a lot more painful, basically, because you're like, oh, I just tore my knee up. I guess I won't be going to school for the next 2 weeks, or something like that. It would be more of a stress factor. So sometimes a bad experience can increase your perception as well as pain, because it hurt really bad before, you expect it to hurt really bad, therefore it's going to hurt. The modulation is your body trying to bring everything back to normal. Your body always tries to go to homeostasis, right? Go back to normal if possible. So your brain starts dumping opioids, endogenous opioids out as fast as it can, including serotonin, norepinephrine. That quiets down the nerve impulses, and it has a very strong analgesic effect. However, as good as that is, and it does allow people in very high stress situations to run on a broken leg to avoid something, or lift a car, and do things that you couldn't otherwise do. It doesn't last forever. If you keep the pain, your serotonin, what happens when you run out of serotonin? What does a lack of serotonin do to your body? Anybody know what depletion of serotonin is? Causes depression. What SSRIs, right, serotonin reuptake inhibitors, are antidepressants, because they create a block so that the serotonin stays in your system, doesn't get gobbled up by your brain. So if you run out of norepinephrine and serotonin, you're going to be depressed. So antidepressants are used a lot in chronic pain management because people get depressed because they don't have any serotonin left. Also, if they work to calm down just the pathways in general, as do anti-seizure medicines. And so for severe chronic pain, they might be used just to calm everything down. So physiologically, there's a couple kinds of responses to pain. So the first one, the top one, is the one most people think of when they think of pain. High heart rate, high blood pressure, high respiratory rate, a little sweating, kind of restless. And that's true. That's what happens with mild to moderate pain. So 1 to 6, about, on the scale, and pretty much things on the outside of your body, not inside your guts, but your limbs, your superficial parts of your body is called. Doesn't mean it's superficial in the sense of, oh, it doesn't matter, because it's still, significant. That affects the autonomic response, which is the sympathetic fight or flight kind of reaction, where your heart rate goes up, you get cortisol and epinephrine, all of that. All that kind of thing you think about with like, oh, that person's in pain, I can tell because they've got a high heart rate. But with really severe pain, like over 7 or above, or visceral pain, meaning your liver is damaged, or your kidneys, you have a kidney stone, something in the viscera inside your body, the opposite happens. And sometimes that's misinterpreted as not being in pain because people are not educated to understand that that's what happens in severe pain. Heart rate actually goes down. Blood pressure goes down. Muscles get very tense because the person doesn't want to move at all. If you have a liver injury, you do not want to move at all. So your breathing is really, really shallow and irregular because it would hurt a lot if you took a deep breath. This is not good for you to be like that, to be rigid, low blood pressure, low heart rate, not breathing. Not so good for you. Causes harm to your body. Both of these are fairly short-term responses because, of course, our body is going to try to achieve homeostasis again. So vital signs will try to normalize within a certain period of time. But this is an emergency. This is something you need to deal with because it's going to hurt your patient badly if they're not breathing. So it's a medical emergency to deal with. However, you can't just look at a patient's vital signs and go, oh, well, look, his heart rate's gone back down. He's not in pain anymore. Good. Happy, happy, joy, joy. Because that's not true. Your body adapts, especially in chronic pain, but also think, what's another reason somebody's blood pressure could be low? Medication. Could be. Maybe they've had too much pain medication or blood pressure medication. What else? What causes your blood pressure to be low?
Dehydration.
Dehydration? What about shock? Blood loss? Yeah. All those things. So you've got to put your thinking caps on. And I'm kind of vehement about this because this happened to me and it was not a pleasant experience. When I had my first fusion surgery, which is a very big surgery, they open up your spine, they put metal rods in, they put dead people's bones in there and put screws and rods and, basically they have to move all the muscles. It's a big deal. I came out of it, and I was in tremendous pain. I mean, this way exceeded all 3 babies that I've had by a factor of 10. And I was, not shy about saying that I was in pain. And the nurse said, no, your blood pressure's so low, you can't really be in that much pain. I can't give you any medicine because your blood pressure's low. Obviously, it must be the medication. And so my daughter tells me I was screaming for about 24 hours, that it took them to figure out that there might be another possible reason a post-op patient could have a low blood pressure other than having enough pain medicine on board. And after 2 units of blood, my blood pressure surprisingly enough went up and they were able to give me pain medicine. But 24 hours of really intense pain is not a fun thing. And it was really stupid. Like really, seriously, I mean, big surgery, possibility of blood loss should creep into your mind. Even if you don't take OR as, part of your education, it should at least come into your mind that if somebody has surgery, they may be bled. And maybe they could use blood. Maybe you could look at something other than just pain and your own, biases. So it made a huge impression on me, like as a nurse, as a person, obviously. and then us teaching it, because like that was a surprise to me. This was a hospital that I worked at. I assumed that they would be very good to me. I think they were taking the best care possible, and yet, what a huge mistake. And it made a lot of difference. I mean, it made me not go and get the neck surgery for years after I needed it, because I was so afraid that I would. And I was just checking into my last surgery, I was literally in tears, shaking, because I was so afraid they wouldn't control my pain. And they asked me, what do you want? And I said, I just want you to control the pain, that's all. And I told them the whole story, and the doctor swore that he would control it. And they did. This hospital did a wonderful job that I went to this time. And I never was really in pain after surgery. But that was my hugest fear, was that that would happen to me again. And I would rather die than have that happen again. I mean, it was like Guantanamo or something. It was just awful. So, response to pain, how you act when you're in pain, or how a patient would act when they're in pain, depends on the context of the pain, what it means to them, their culture, and their own pain tolerance. So a lot of times we believe something is supposed to hurt. I mean, basically if you're having a baby, you're delivering a baby, you know it's going to hurt. So you're expecting it to hurt. You know it's going to be over. So you can tolerate a lot more pain than you could if you thought, this is going to last forever. You know, that would really kind of be hard. The cultural ideas, like men don't cry, that we have, you know, man up, man. Suck it up. You know, or you're not really supposed to ask if you're of a certain, like some ethnicities, Asians kind of say, no, we shouldn't, you know, shouldn't complain, it's weakness. Some Mexican, Latino men, especially, are not supposed to show pain. You know, just not supposed to whine. Don't be a whiner. Those are not so good. And a lot of patients really don't want to bother the nurse. They really, honestly, just think they're being a bother if they call for pain medicine. So we need to educate them. And if they don't, if we think, okay, they just had surgery, and they haven't asked for any pain medicine, and it's been 5 hours, let me go check and ask them if they're in pain. Because they may just not want to say. So we don't want to just wait for them to get on the call, right? We should be giving it to them or asking them. Nonverbal things, if somebody isn't able to speak or is unwilling to speak to you, you can look at things like their body movements. Are they restless, indicating that mild to moderate, or tense and still, indicating super high pain? Are they holding a part of their body or guarding their abdomen, something like that? Are they, you know, you know, yeah, you are. Clearly, something's bothering you. Yes.
Somebody's in pain and you can see that they are, but they won't. They just want to.
They have the right to refuse medication if they want. We can't force them to take the pain
But I
medicine.
mean, would you always tell them, like, do you want some pain medicine? I'm going to give you some pain medicine, or is there any? Is it just kind of ordered after surgery or whatever?
Well, it's sometimes it's ordered like on a regular basis, like, you know, every 2 hours, or but usually now it's PCA pump, so they'll be in charge, and usually people will deal with their own pain. But if somebody, you know, they come in and they have a broken leg and they say, nope, I don't want anything, you know, I'm not in any pain, doesn't hurt at all, nope, no, go ahead, it's not hurting at all, and then they're obviously in pain, I would ask. I would be kind of really wanting to know, like, tell me what's going on. I mean, I can see you're in pain. It's fine. I mean, you expect to be in pain. You have a broken leg, for Pete's sake, or arm, or whatever I said it was. And maybe there is something going on. Maybe they're an ex-drug addict, and they're afraid if they have one more dose, they'll go back to heroin or something. Maybe they have misconceptions.
Like when my boyfriend broke both of his ankles in a work incident, and he was convinced if he didn't take his pain medication, he'd go back to work earlier. So
That's
he didn't
totally
want to
the
take
opposite.
medication.
Yeah, I bet that took him a long time to get back to work.
Only 2.5 weeks.
Yeah, he would have probably gone back a lot sooner if he would have taken his pain medicine and could have got to his physical therapy. So yeah, we need to actively find out what's going on, because we know that people are going to be in pain if they break both ankles. Wow.
It was a long summer.
Yeah, I guess. And he's probably a baby too.
What did he do?
So
What did he do? He had 2,000 pounds of steel falling.
oh
He
geez.
was supposed to have both his feet amputated.
Oh my gosh.
He managed to.
That's horrible. So just because someone doesn't ring the call light and demand medicine doesn't mean they're not in pain. They certainly, you want to be active about asking them if they're in pain. Wow, that's extreme though.
He walked on too.
Oh God, that's bad.
Yeah.
Not smart. Not smart. I would not allow him to take care of you when you're incapacitated in any way.
Well, then again, then I had him for 6 years later.
No, I wouldn't allow him to have any. You'd be like, well, go ahead and walk on it. It's better. You can tell him he's wrong. He would have gone back sooner if he would have took his pain medicine.
You can tell me what I think.
It doesn't matter. Yeah, there's probably no point. I find that a lot with people. Okay, so the few types of pain. I didn't say men, I said people. Acute pain is a protective function. If you broke both your ankles, you probably don't want to walk on them for a good reason. They hurt in order to tell you, don't walk on me. They're broken. Shards of bone will be up into your body and you'll have all sorts of tissue damage, and it's a bad thing to do, so don't do it. So acute pain is good. It's a good thing that we have it, because otherwise we'd all be walking around on broken ankles or other things. And there's usually an identifiable cause. We can say, look, your ankle's broken, that's why it hurts. Or a baby's coming out of you, that's why it hurts. There's usually fairly limited tissue damage. You know, I mean, yeah, broken ankle causes tissue damage, but not complete. It's limited to an area. And there's usually not a tremendous emotional response because the person can understand what's going on. You know, it's okay, my ankle's broken, it hurts, it'll get better in a few months. It lasts a fairly, you know, usually about less than 3 months would be acute pain. Anything that's longer than 3 months, you're starting to look into longer term and more chronic, but not necessarily. It can cause harm if you don't take your pain meds, and that decreases your mobility, and you don't, and then you get a bed sore or constipation or pneumonia or DVTs or something like that. Or if it uses up the person's energy, because it hurts. I mean, pain uses energy. When you're in active pain, it makes you tired, because it takes a lot of energy to deal with it. So the goal in acute pain is to control the pain so the patient can get up, ambulate, do their physical therapy, participate in the recovery process. And this is just repeating the decreased pain increases mobility, which means decreased complication and length of stay, which is good. Chronic pain is almost exactly the opposite of acute pain. It serves no purpose in the body. It doesn't do any good. So if my back hurts and I say, I better lay down because I shouldn't be standing up because my back hurts. If I did that every time my back hurts, I would never get out of bed. Never. That would not be good for me, right? We know immobility is bad. Pretty soon I would have all the signs and symptoms of immobility and I'd be unemployed, which would not be a good thing. And so it would serve me no purpose. So it's not protective to the body. It's just random crap that doesn't need to be there. Doesn't need to be telling me this. I already know. It lasts way longer than anticipated, and there is no exact cutoff date, like if it's 3 months it's acute, if it's 4 months it's chronic, but if you're looking at years, it's definitely chronic. More than 8 months, usually considered chronic. But if it's like, you know, you have a knee surgery, it may take you 6 months to recover from it. That's still acute pain, but it's just a little bit longer acute. A lot of times chronic pain has an identifiable cause, but sometimes it doesn't. And that's even harder for people. So think about like fibromyalgia, some of the regional pain syndromes and stuff. Somebody has pain and it's really bad pain, lasts for years and years and years, but there's nothing anybody can find. There's nothing on MRI, there's nothing on x-ray. Nobody knows what causes it, and for many years people with several of these kinds of diseases were just basically considered malingers, fakers, maybe even drug seekers. And now we know that they are very real diseases, but we still don't know why they hurt. So these are a pretty big deal, and that makes it even worse, because if you don't know why it hurts, then it's even more confusing. Like, you don't know what not to do, or, you know, anything. And it impacts every part of a patient's life, which acute pain does not generally. So people don't, their social life is attenuated because, they don't really feel like going to do something if their knee's always hurting really bad. They're not going to go dancing anymore or something like that. They probably might have, differences with work, with ADLs even, relationships with others. If you're in pain, you're usually not the nicest, pleasantest person that you could be. You're not your best person, maybe a little grouchy. And so if you're in pain every day, maybe you're grouchy every day, your relationships might suffer. And so depression and suicide are super high incidence in people with chronic pain, especially undertreated chronic pain. Causes a high degree of disability, can cause isolation from other people because, really, let's face it, who wants to be around someone that's always like, I'm in pain, I'm in pain, I'm in pain, I'm in pain, I'm in pain. I mean, if I said I'm in pain, I want to go home, I want to lay down, every time I thought about it, you'd never see me. I mean, I wouldn't be here now. I wouldn't have been here last week. I wouldn't have been here the week before, the week before, the week before, the week before. I have not had a day without pain since 1987. So basically, I wouldn't have a life if all I did was say I'm in pain every time I'm in pain. I would have no life, no friends, nothing to do at all. And that would be stupid because who cares? Nobody wants to hear that. I don't even want to say it that often. At home, we have a system where my husband doesn't have to ask me and I don't have to say anything. I can just either hold up a sign or put something on the refrigerator or something if I'm having a bad day, and he doesn't have to say, so how are you feeling today? Or something like that. And we used to have other systems. But we do need to think about energy drain because it does take a lot of energy. So if I go home from work, like my daughter and I have the same kind of the length of day schedule. I mean, she's younger than me, but she's basically not that young. She's in her 30s. She'll go like, I'm going to go to the grocery store. I'm going to go to this. I'm going to go do this. I'm like, really? I'm going to go lay down. Like, I'm tired because it takes energy. And ADLs can be affected. I don't want to go to the grocery store. Are you kidding me? It's all I can do to get to work and back and, do my normal stuff. I'm not going to go to the grocery store. Took care of the kids. I did my stuff I have to do. No way. No, somebody else goes to the grocery store. So what? Not going to back and eat it. It's a good excuse. It's a good excuse to you. Too tired. So that can sometimes lead to something called pseudo-addiction, which will come again later, where people go from doctor to doctor or ER to ER looking for pain relief because they don't get treated. People with undiagnosed things that cause pain or undertreated pain, at some point you just need a break. You need it to stop for an hour or two. You need to get some sleep. And so they go and they say, I have this migraine, it's killing me, just please give me some Demerol. They get a note in the chart saying drug seeking. And they really do have migraines. And if you've ever had a migraine, you really, really, really want it to stop hurting. And if you feel bad enough to have a migraine and get in the car and go to the emergency room, it must be really bad. Because you don't feel like going anywhere when you have a migraine, right? I mean, only some people have migraines, but they're pretty painful from what I only had them before I ever got pregnant, so that was a long time ago. Getting pregnant either usually cures them or starts them. Starts them or stops them. So. Then you have cancer pain, which is kind of in its own class, only because it can be so complicated. Most cancer patients have some kind of pain at some time. It could be pain that's acute from the tumor pressing on a nerve or pressing on an organ. It could be chronic pain from a surgery. It could be metastatic bone pain. It could be in the brain. It could be nerve pain caused from a brain metastasis. So you're looking at a huge range of different kinds of pain, different treatments, very complicated to think about. And then there's something called pain by inferred pathology. And this is an interesting one because nurses are really key here in their assessment, and documentation is key in diagnosing these kids. They're not necessarily kids, they're often adults. If somebody tells you, if you say, tell me about your pain, or describe your pain, so nice and open like that, and they say, anything that has to do with electricity. Oh, it's like shock, little zip, little, kind of like electricity, or like I'm getting shocked. or, anything like buzzing, shooting kind of thing. That's nerves. That's exactly what it sounds like. It's electricity. It's the nerves causing that pain. So neuropathy, when you see, or a physician sees, that a patient has tingling, electric sort of numbness, tingling, pain in their leg, lower extremities, they know that's neuropathy. Because that's how you describe it exactly, and everybody describes it. It feels like when your foot goes to sleep and then you stand up and start to walk around, it starts to wake up. That shooting pain, that's what neuropathy feels like all the time. So imagine having that every day. Annoying, right? Very difficult to treat too. Can't be handled with narcotic pain medicine or non-narcotic pain medicine. They have to give them either antidepressants or sometimes anti-seizure medication because those calm down the whole nerve transmission. And so those work. But that's what that is. And then idiopathic pain is the worst because there's no cause that we know of, but the patient has pain. And that is, we need to validate that pain for that patient, because even though we don't see the cause, doesn't mean there isn't a cause that we'll discover 5 years later, or that they're not feeling it. And when you get things like these regional pain syndromes or something, if somebody has something like that and you start an IV in their arm, they might have shooting pain that runs all the way up their arm really bad, and they're like screaming, and you're like, holy crap, all I did was start an IV on you. You need to deal with that pain. You need to address it. Or they may be in the hospital every 2 weeks. Like people that come to pain clinics go there for regional anesthesia every 2 weeks forever to get a block, because otherwise they can't stand the pain, which would be really hard because these are kids. We're talking about 8-year-olds having to undergo anesthesia every 2 weeks because somewhere, back in the past, something happened that caused them a lot of pain and it got stuck somehow in their brain. We don't know why. And then our knowledge, attitudes, and beliefs is important in pain management because of patients' belief systems, nursing, healthcare, family. And the fact that pain is so subjective makes it really hard to get a black and white fix on. And a lot of people really want this black and whiteness. They want a number. They want something they can, be sure of. So pain is always what the patient says it is. It doesn't matter if they have a paper cut. If they say they're 5, they're 5. And that's what you treat.
From experience, have you ever, not given a pain medicine because you think that they're drug-taking? Or
No.
do you just always...
No. It's not... Your job as a nurse is to treat pain. Your job is not to be a psychiatrist and diagnose drug seeking. Even if they were drug seeking, your job is to treat the pain and then educate them about alternative coping mechanisms or refer them to a drug clinic. But first treat their pain. Because they're legitimately in pain, even if they just have emotional pain, they're at least legitimately in pain. So our job is to assess and treat the pain, not to make a judgment about why the person's having pain. And that's good, because I don't want to make that judgment call, and I would never want to withhold pain medicine from somebody. So it's always, and this is, you can guarantee at some point I'm going to ask you this. Pain is what the patient says it is, not what you think it is. It may not be on this test. It's going to be on a test, for sure, because it's important. So a bunch of studies have been done on pain management, and this, since it's an area of interest of mine, and also because I feel so guilty about all the pain I inflicted on all those neonates all those years before we knew that infants felt pain and stuff. I mean, I knew it, but the doctors didn't believe it. That nurses have a big bias sometimes, and one of them is exactly this, drug-seeking pain. I think they're drug-seeking. So what? It's not your problem. Leave that to the doctor. You deal with the patient. The patient's problem is they need medicine. Give them the damn medicine. You're not going to create a druggie. You're not going to, do anything to harm them. And then fallacies that have caused so much trouble over the years. For I don't know how many decades, even the very best neonatologists and pediatricians thought that infants don't feel pain like adults. Therefore, infants are, up until maybe 10 years ago, were circumcised without any pain medicine. Then we started giving sucrose water, which is just sugar water. I mean, it does work really well on newborns. But they should be given a lidocaine block. It's a very painful procedure. It's a surgical procedure, and I highly encourage all of you to go watch one when you do your mother-baby rotation, especially the men, because it's surgical. And if you're intending that your future sons should get that done, you definitely should watch it. All of you men and women. If you intend to have your sons circumcised, you must be required to watch it if you're in my rotation. Because it is not comfortable, let's just say. But also, I mean, when I was a NICU nurse, it was a common procedure that a chest tube would be put in without any pain management. Central lines that might take an hour or two to put in a PICC line, they get sugar water. Intubation, long-term ventilation, no drugs. Now usually the standard of care is that they get a fentanyl drip, like an adult would. But at that time, the thought was that they would get addicted to fentanyl. Now I'm thinking in my head, this little preemie out there in the alley going, I want to score some smack, man. That's what addiction is. Addiction is use despite harm and impaired control. Little babies don't go out looking to score smack, right? They're not going, oh, morphine, give me some more morphine, getting in the drawer, trying to shoot up. They're babies. They don't do that stuff. A lot of older people also think, and regular sized people, I mean normal, in between people, think that even using regular pain medicine will cause addiction. And that might have been part of what your boyfriend was worried about, was that he would get addicted.
Yeah, we could have gone back to work.
Well, you can certainly go back to work when you're on medicine. It doesn't, pain medicine at the level that it's appropriate does not give any positive side effect other than the relief of pain, which is a misconception that people have, like you're going to get high, like, you're in pain, you give a patient a Vicodin because they're in pain, and they're going to get all high or something, and they don't. They don't get that if they're in pain. They only get that if you're not in pain and you take it. If you're just in pain and you take it, you get nothing, except a relief of pain, which is in itself the best thing that you can get, pretty much. And then, I've had people in hospice tell me, I don't want grandma to take that because she'll get addicted. Again, I'm like, she's not going to the alley. We're going to give her all the morphine she wants. She does not going to get addicted. Believe me, trust me, she won't get addicted. Not possible. She might get dependent, but she's dying. We don't care if she gets dependent. We're not going to try to take it away from her. And a lot of people believe that all old people are in pain. It's just a normal part of being old. Old people don't need to be in pain. So get them out. Things that influence pain. Age influences the way it's interpreted and communicated. Babies cannot tell you where it hurts. They can only cry. Old people often cannot necessarily, they have cognitive deficits especially, but also sometimes just communication problems. Sometimes can't pinpoint exactly what's starting the pain. They know they're hurting, but they can't exactly tell you where, or they can't communicate well to you. So certainly up until, about age 2, you're not going to have a kid be able to tell you quite what's going on with them. They might be able to go, owie, owie, but not like what happened and what makes it worse and old card and all that stuff. Fatigue is going to make pain worse. It decreases a person's pain tolerance. So your patient's tired, they're going to feel the pain more. Sleep in this situation is not telling you that you've done your job and relieved their pain. What it's telling you is your patient is so tired they collapsed and went to sleep. And they're still probably in pain, and they'll wake up in a little while in more pain. Genetics does determine your initial pain threshold. So some people are just born able to tolerate a lot of pain. And it can also be learned to tolerate a lot more pain. But generally you're just born with a certain pain threshold. Neurologic function has a big impact on how pain is interpreted in terms of if your central nervous system is working, you may not have any feelings. I mean, you may not be able to feel if your hand is on fire on the stove until you smell smoke. On the other hand, you may have phantom limb pain. You may have, and an inability to communicate. You may not be able to pull your hand away. So neurologic function obviously is going to have a lot of impact on how that works. Social factors have an impact on pain because distraction can be a really big deal. It can be a very good adjunctive therapy. Paying attention to the pain constantly actually kind of makes it worse. You're focusing on it all the time. So you don't always want to be thinking about the pain. You want to kind of get a little distraction. Think of something else, watch a movie, listen to music, talk to some friends. And that's a good way to kind of get, a little extra pain relief. It won't substitute, but it does help. And family and social support is really important in anything that's a stressor, which pain is, and can help decrease the effect. Spiritual things, spiritual effects can be kind of negative or positive, because some religions or spiritual beliefs kind of make people think, well, there's just a certain amount of suffering you just put up with. Like, life is suffering. That's what it is. And so they're just suffering unnecessarily because they think that that's cleansing their karma or whatever, or that's what they're supposed to do. On the other hand, spirituality can be a huge support system for people and a huge coping mechanism, so that can be a real positive. Psychologically, anxiety, as we said at the very beginning, the more anxious a person is, that increases their mental tension and increases their pain. They're already in pain, they're going to be increased. So if we can relieve their anxiety, which is probably about whether we're going to relieve their pain, then we can relieve their pain. Their coping style as well makes a difference. So if they have a control-based coping style, the more control we give the patient, basically the better. And we're going to talk about coping a little bit less. So we want them actively engaged, which means like the PCA pump, the reason those work so well is partly or largely because the patient is in charge. They use way less medicine, way less medicine than they would if it was the nurse coming in every 2 hours giving them a shot or waiting till they needed it. So they're working much better for the patient, and they're using less pain medicine, so that's good. Culturally, we know the meaning of pain and how it's expressed are culturally driven. The role in the family can also have an effect, because if you're the strong one of the family, you're the matriarch or the patriarch, or just kind of the one that gets things done in the family, you may not feel like you can be in pain. It's not what you do. You're the strong one that comforts other people. You're the nurse. You're not the patient. And so sometimes it's hard to get out of that. So when we're doing assessment, we have to look at the client, right? Client's expression of pain. Their description is the most valid indicator there is. So you ask them the most open-ended question possible. I know you've been taught to specifically old cart and taco or whatever the heck other things you've got to do with it. No, you don't eat taco wound, right? Why would you put taco and a wound together? That's so gross. What if you wanted to eat a taco after that? Pretty gross. So, but if you can start your assessment by asking them to describe their pain, or tell me about your pain, something general, then you might get more information. And then if they leave out part of it, then you can go in and finish. Like, when is it worse? What makes it better? What is it, if they're going to tell you plenty, generally, because people that are in pain would like to tell you about it for the most part, especially acute pain. So we want to know what makes it worse, what makes it better. How is it making the behavior of the client change? And what about anybody else?
So, kind of related to the thing, but so the pain associated with paralysis, what would you call that?
I would say that would be like,
That's still neuropathic?
it could be a kind of neuropathic pain. Yeah, that's fairly recently been discovered, or like not discovered, but solidified. Because everybody thought, oh, you're paralyzed, you can't feel anything.
Right.
But a lot of paralyzed patients feel quite significant pain, and so that's neuropathic because it's nerve. And they don't know what part of the nerve. They think it's in the brain, not in the leg, because it's similar to phantom limb. So yeah, it's probably in your brain, or their brain, somebody's brain. I don't know whose brain, but not mine. And then So we want to know all these things, and then we want to know what the client needs. What do they want to do? Do they want to go back to work? And if they just need enough pain medicine to go back to work, great. If they need enough pain medicine to get up and ambulate so they can get out of the hospital, that's the most common thing. Some people just need, they need less pain management. Usually, as a general rule, you can say 3 or less on the pain scale is a good goal. That allows people to function. Most people can function at 3 or less. But if they get above 3, they need medicine. And then one thing to think about, if you ask a patient and they say 8, no, 9, my pain is a 9, my pain is a 9. Do you want an old cart now? 9, hurry, 9, I'm screaming, I'm in pain. No, don't old cart them. The only time you do follow-up before you get pain medicine on board, you go, yes, I'm going to get you some pain medicine. Unless they just walked in or they have chest pain. If they have chest pain, we need to find out if it's cardiac. And that's a very important thing to think about, because if you just give them morphine, then you don't know whether that was cardiac and they're about to have a heart attack, or that was something else. And, what was their rib muscles or something like that were hurting. So in cardiac, for chest pain only, you have to go in a specific sequence. And the book describes it under the cardiac chapter. But briefly, you give a cocktail that includes a numbing agent that they swallow to rule out GI pain. Then you give nitroglycerin, which tells you whether it's cardiac pain. If it doesn't go away after the nitro, then you give the morphine. Because it'll go away. If it's cardiac pain, nitroglycerin will take it away. And so, but that's the only time. Other than that, you go, where does it hurt? I'm giving you medicine. And because it is an emergency when someone really has it. We don't want to be like, oh, so what makes it worse? What makes it better? When did this start? Can you tell me more about how it feels? They're going to slug you or kick you or vomit on you or something. Because really bad pain will make you throw up too. That's one of the things that severe 7 out of 10 or visceral pain will do, is you will vomit. The patient will start vomiting. And that will tell you right there that patient is in really bad pain. So some of the nursing diagnoses, and these can look at the effect or directly address the pain. So you could say acute pain related to tissue trauma, as evidenced by pain scale rating 8 out of 10, clutching abdomen, and abdominal incision 1 day ago. They've had surgery, they've got an incision, they're clutching their abdomen, they're screaming in pain. Good indicator, they're in pain. You could say that they have ineffective coping related to chronic pain, chronic undertreated pain, as evidenced by patients stating, I can't do this anymore, and attempting to jump off a bridge. Or coming to the ED for a shot once a month, for Demerol once a month, and saying they can't take it. Ineffective role performance if they can't do their job because they're in too much pain. That's basically what that is. Disturbed sleep if they're waking up at night because they're in pain. That's disturbed sleep pattern. So goals generally focus on safe use of pain relief, especially medications. We want to think about safe use. Pain level at or below that agreed upon number, which is, if a default for care plans, I'd say 3. But some patients can't take 3. They need a 2 or a 1. 0 is not very realistic. I know most of you are probably sitting there at 0 right now, but it's kind of unimaginable to me, like what 0 feels like, because I don't know. But most people are not going to go to 0 in an acute situation, or even in a chronic situation. It's just overkill. They'd be so drugged up by that time that they wouldn't be doing it. So you want them to certainly understand about, taking their medicine before they get up to go do PT or whatever. Push the button on the PCA before you go to the bathroom, that kind of stuff. Because it's going to hurt more when you go up and exercise. So you want to pre-medicate prior to exercise. Splint the abdomen before they cough if they've had an abdominal incision. It's going to hurt, right? And also they could dehisce that wound, which we really don't like because we didn't like those pictures. Priorities, it depends on the client. This is client driven. Do they need just to sleep? Most patients, what they want is they want to be able to sleep. They want to be able to go to sleep. They're tired. They want you to make the pain stop so they can sleep or eat. Maybe they want to be able to get up and do their physical therapy and go home, for God's sake. Go back to work. In a lot of cases, you're going to be treating pain so that a person can maintain their dignity and their relationships while they die. Because terminal patients have a lot of pain, a lot of times. And you want to keep their pain low enough that they can be dignified, that they're not on the floor writhing and screaming, which, believe me, is really undignified, or crying, but that they can still speak to people so that they can say goodbye. And that's a pretty hard balance sometimes, because there's a lot of pain there. I mean, if you're giving huge morphine doses and then oral morphine every hour and gel morphine on the pressure ulcers and stuff, you're like, holy crap, this is a little old lady that weighs like 57 pounds and I'm giving her morphine enough to drop a horse. But people build up a tolerance over time, so you really use big doses of morphine on these dying people. So intervention-wise, implementation-wise, do a lot of client education, certainly on how to take their pain medicine, how to use different techniques, but also when they should come back and seek more treatment. If this hurts more, if it doesn't stop hurting, if this doesn't work, those kinds of things. And before we do something painful, we need to prepare the patient. We don't go, oh, this won't hurt, and then shove a Foley in them. Yes, it will. I can promise you it will hurt, and so will the IV. I really think you guys need to be doing these things on each other. Not the Foley, but you need to be starting IVs on each other, putting NG tubes down, that kind of stuff. That's very, very useful. I mean, you should have new equipment, I'll give you that. You should have like a sterile set. But you really should try it, because if you don't know what it feels like, then how do you know what it feels? I mean, how do you know how to do it right? And also, why not do it on somebody that is not a patient first? Like, do it on a willing volunteer. So, don't forget the holistic care in pain. Now, we're treating the whole person here. Remember the emotional component, the spiritual parts. We need to treat all that. So we need to think about emotional stuff, because it's a pretty emotional subject. And also about rest, exercise, nutrition. All these are important. When we're healing a wound, we need nutrition. We'll be learning more about that, but we learned some about that in skin and wound. Relationships may need attention, because people in long-term pain certainly have relationship issues sometimes. One partner may not know how to react, may not want to deal with it, may not deal well with it at all. And adjunctive treatments are super important. So we're not just going to go med, here's some more med, here, go ahead, just take it off. We're not going to do that, because we have other things. We have brains, we have judgment. So we're going to use a lot of non-farm ways to control pain as well. Or instead, we're going to use relaxation, guided imagery. That works really well for some people. Distraction works very well, especially in acute situations, as an extra thing to, add on. Biofeedback is a specialized, you obviously aren't going to learn that in school, but you could take a little course on it and, potentially teach someone how to sort of meditate, drop their pulse rate a little bit. And a lot of the cutaneous stimulations, the massage, the hot and cold, are things that we can do by ourselves, and they do a very good job of relieving the muscle tension, reducing the pain that comes along with muscle tension, anxiety, and also it just reduces pain, because it increases the circulation, which can help with pain, and it triggers that gate control. Those C fibers are bigger, they take over and give you positive that outweighs the negative. TENS unit is an electrical unit that does the same thing, but in your spine. Basically, it overwhelms your spine so that it doesn't pass through the pain sensation. It works really good for some people, and for other people it irritates them just to no end, so they can't use it. Herbals are pretty useful for some patients. Now that some of them are legal, I'm sure more people will be using them. I decided this at the earlier class that next quarter I'm going to put an evidence-based practice thing in the jar about how if marijuana is useful, and we like, how is that working for relieving pain? Because some people are saying, oh, it works really good, and I don't know, maybe I don't know that recreational blends would, because they're not made for it. It's a completely different product. It's a different type of thing that they use for medicinal, is like an indica, and the other one's what, sativa. So I don't know if it works the same, but well, I would assume they're related well enough, but it'd be a good question to do for evidence-based practice. And then we want, but there's other herbal things too that can work. Reducing painful stimulation is something else we can do for patients. We can reduce other sources that might be painful. So in their client's environment, bed linens, simple thing, pull them, get the wrinkles out. That's one thing out of the way, right? Clean linens, nice. Temperature of the room, we can handle that. Keep your stiffness down. Repositioning the patient, get them in a comfortable position. One less thing that hurts, right? Change the wet dressings, wet clothes. That's an uncomfortable thing to have bloody dressing or wet, depends or whatever on you, I suppose. Monitoring equipment, hot and cold things. If you leave that cold pack on for a long time, it's gonna hurt. It really gonna hurt. And sometimes you have monitoring equipment or something, and it could get painful, the cold or something. And prevent urinary retention and constipation. One of the things I noticed working with hospice patients is that they can have tremendous pain and be going a long time, but boy, if they get constipated, it will put them right over the edge. Like, totally, it's either really painful or it's just that tipping point. Like, and I'm not sure whether it's that painful or if it's just a tipping point for them. But they will just go nuts until you get them unconstipated. They're just in unbearable pain. So, again, I just haven't taken the time to find out, like, why is this tipping or is this that it's really that painful to get constipated. But most pain medications, remember, cause constipation. So these people that are taking giant doses are probably constipated. So they're also usually almost always taking a stool pill. They should be, if they're taking an opioid. So implementation, here's finally the drugs. We're down to the drugs now. I'm not going to tell you exactly which drugs. Like, I think I answered some of these questions just before that class officially started. You don't need to know exact doses of drugs. Oh, you would give Percocet for 4 and ibuprofen for 1, or not for me, certainly. That's way too specific, and there's not rules like that anyway. Depends on your orders, and it depends on your patient a lot. But you need to think, like, this is a typical order. RN will administer analgesics as ordered and reassess pain 30 minutes after an hour. That would be a very typical type of intervention that you would write. You're going to want to assess pain every hour. So you're going to have, you want to be familiar with the actions of NSAIDs, of, like Tylenol type non-opioid pain medicines, opioids, and then adjuvant medications. Like tramadol is a medication that isn't either, kind of doesn't fit into either category, but it kind of just helps boost the other drugs a little bit. And Toradol is like a NSAID type thing, but it's an injection. PCAs are very good because, like I said, the patient's in control. They can hit that pain before it gets really super bad. There are also local analgesic infusion pumps you will run into patients with. You may know people that have them. They pump medicine usually into the spine. So there's a catheter, and then it's tunneled under the skin to a pump that's usually put on the abdomen. And it's filled with like morphine, and the morphine goes right into the person's spine. Very effective, as I understand it. That was one of my options, but I don't know. I'm really worried about the infection risk of having a catheter in my spine. Just like worries me, so I haven't done that. Topical analgesics are really surprisingly effective, and I highly urge you to use them for your patients. They will work on about a good inch down. So it works on bone pain, works on fairly deep pain, won't work on like liver pain or, internal pain, but, like it's just lidocaine patch. And so 12 hours, you got 12 hours of good relief for a pretty big area of muscle pain or something. It's a good job. And there's topical anesthetics too. And then there's local and regional, like, epidural blocks, or you can get a brachial plexus block. You can get basically any part of your body blocked off. Clot block for, if you're going to get a circumcision. There's also surgical interventions for pain management. They just do a lidocaine block in the clot formation in order to make it not clot block.
excellent on it.
Okay. Okay. I totally would not say that. There's surgical interventions that are very effective, and this is actually what I do. It's like every 6 months I go in and have what's called a rhizotomy, where they take and they use radio frequency and burn out the nerves in your spine so that you don't receive pain messages. They're little nerves. They're not the big nerves that you think are your spinal nerves. They're the little nerves that are getting the message from your spine that it hurts. And so they just burn them back, and they grow back, unfortunately, faster than they should. Very nice, though. It works well for kids with, it works well for paralyzed people, actually, too. So it must be below the brain. It works for that. It works for, they use it for kids with CP, too, for spasticity, but that's the other kind of nerve. A rhizotomy, R-H-I-Z-otomy. And it can be done, now it's done with radio frequency now, mostly, so it's not like a knife, but you can do it open.
Oh, so is that like that the laser thing you can...
Well, they stick in a wire, and then they just send current through it. And it's done under X-ray, under live X-ray. So you're under like pretty heavy sedation at the time when they do it, because it's a fairly long procedure. And then there is chronic and cancer pain management. It's sort of a field of its own. There is, pain management specialists that you would want to use. You'd want to put your patient, refer them to a clinic, a pain clinic, because those are people who deal with this all the time. So some of the barriers to good pain management that you hear from all areas. Fear of addiction is the biggest one. Believe it or not, that is still the biggest barrier to good pain management. And that comes from everywhere. Doctors are afraid of getting patients addicted. Patients are afraid of getting addicted. Nurses think that they'll, help somebody get addicted. I'm not really sure. So you should know the meaning of these terms. Dependence is a physical adaptation that will result in withdrawal symptoms. So I take opioid pain medicines every day, and I have for 30 years. Almost 30 years, right? Or over 30 years? God, 87, I don't know. Somebody do that. I'm too drugged up. I'm kidding about it. So if I stop taking it abruptly, I will get very ill because my body depends on that medicine, and also because I'd be in roaring pain. So I'd probably be really sick in both ways. But I am dependent on the medicine. I can't stop taking it. I'll get sick pretty fast, usually within a few hours. Like if I miss a dose, I get sick within about 3 or 4 hours. Tolerance is what happens when you have pain medicine. You take 5 milligrams of something for 6 months, and then pretty soon you need 6 or 7 milligrams to do the exact same thing for the exact same pain. Your body just builds up a tolerance. So again, these are true things that actually happen with all opioid medicines. Addiction, however, is defined as impaired control over use and or use despite harm. So I do not have impaired control over use. I only use my medicine appropriately. I've been using it that long. I've never had any problems, never got high off it, unfortunately. Yeah, I mean, it would be nice to know what it would be like, but whatever. And so there's no addiction there. And people they really think people are going to get addicted, but they're not. They're misusing the term. So if we as nurses can properly use the term, then we're not contributing to that. We can say, yes, she'll become dependent. We will have to wean this child, this baby, off the fentanyl. Slowly decrease the dose because they'll be dependent, but they're not addicted. They're not going out on Colfax trying to score some smack because they're not addicted, because we're going to treat it right. And pseudo-addiction we talk about. It's usually for undertreated people. And there's a lot of people with it because one of the systemic problems is that right now the FDA audits any physician that writes a certain number of prescriptions for pain medicines in a given month, on a monthly basis, gets audited by the FDA, and they don't want that. So some doctors just won't write any. They just will say, I'm not writing any long-term prescriptions, just go to some other doctor, go to the pain doctor and let them do it. And usually anesthesiologists are the pain management people, because they're pretty comfortable with drugs, because that's their job, is giving meds. So nursing implications. Definitely accurate, safe medication. So we do not want to screw up on our drug administration. If you mess up your dosage calc and you're given morphine or something like that, it's kind of serious because people do stop breathing. Or if they're on a PCA pump, or something like that, or a drip, and they're not breathing, what are you gonna do? What's the first thing you would do? If you walk in the room, patient's on a morphine drip, and they're breathing not at all. Or they're breathing, let's say they're breathing twice a minute. You barely stop breathing. Stop the machine. Quit giving them the damn medicine. Yeah. Just don't give them anymore. Let them recover a little bit, and then maybe like do some good assessment. But stop giving them the medicine. If you're pushing on med and they stop breathing, then for God's sake, stop pushing. Unless that's the intent or that you know. You assess both the effectiveness of the medication and the side effects of the medication. And there are lots of side effects. And if you don't know, if you get a certain drug, you go, oh, this patient has hydromorphone. I don't know what that is. You don't go, I don't know what that is. You look it up. Always look it up, because you can't memorize all the drugs. And you will have a drug resource. It's mandatory that all medication rooms have a drug reference. And as nurses, you will also have access to your cell phones, which you will not as students. Believe it or not, you can't bring your cell phone at all to clinical. You have to leave it in the car or the locker room. So get used to not checking your cell phones now. It might kill some of you. Use the appropriate drug when given a choice, and patient education is really important. But this is a big thing, because you are given a range. Like I've said before, you get a range order. It might say you can give anything from 2 Tylenol, 2 Percocet, 1 to 2 Vicodin or Percocet, all the way up to morphine, depending on the pain the patient's in and how much time. And then it's up to you to assess, make a decision, and administer that and document what you've given and how well it works. So you may have to play around a little bit with it, but you know, you have a pretty wide range. So there isn't a hard and fast rule of when to give what. But there is usually, you know, you'll learn some general things. And then you want to treat pain usually be at like 4. You don't want pain to get up, it's certainly not past 6. And it's more effective to treat pain as soon as it hits 4 and teach your patients, if you get to 4 on the 10 scale, then call me and I'll give you your medicine. Because it works better to treat it then and keep it low than to go up, down, which is very bad for them physiologically. If needed, you can refer to a pain clinic, a palliative care, or a hospice. And then to evaluate, remember that you need to assess based on what you've given, and especially the route that you've given it. So it needs to be at the peak. If you're giving something by mouth, it does no good to come back in 15 minutes and say, how's that drug working? Because it hasn't worked at all. It hasn't even got dissolved in your stomach in 15 minutes. And that has to do the first pass effect with the liver. You remember all that stuff? Well, you just learned it like 5 minutes ago, right? So you should learn it. You should remember it. So you got to wait. Usually 45 minutes to an hour for a PO med is going to be about the peak. About an hour later, it should really be working. For IV meds, it can range anywhere from almost instantly, they should feel better, to 15 minutes to half an hour. So you want to get the peak effect. So 15 minutes to half an hour would be good for like IV meds, because they should still be feeling pretty good. They shouldn't wear out. And then if you get partial, so the patient's at 6, they want to get to 3, you give them the drug, they say, well, it's like 4.5 or 5. So okay, you don't really want to give them more drug because you just gave them the drug. So put some ice, reposition them. Try some massage, try a little distraction. You know, add something that's not med. And then if you consistently come in, Mr. Jones always is in number 6 pain. No matter how much you give him the pills every 4 hours, he's always feeling pain. Then you need to talk to the doctor about maybe getting him something stronger or something different, or even a one-time dose to just bring it down to a manageable level so we can keep it manageable. Side effects, we certainly want to evaluate that. I mean, if the patient's vomiting all the time, then the drug's not going to do a whole lot of good. Or if they're, you know, unconscious. And then we need to document, obviously, what we did, but also document and communicate what worked. If you finally figure out at 3:30 that the best thing for Mr. Jones is to take his medicine, put him on his left side, and an ice pack on his right hip, and put a pillow under his left arm, please tell me when I come on, so that I don't have to reinvent the wheel and put Mr. Jones tell again while I figure out about that whole thing? Because you've just figured it out. Tell somebody. You know, you're smart. So also then validate with the client, like what really, you know, yeah, that really hurt. I'm glad that we could help, that kind of stuff. Make it, you know, make the pain go away. That will be very good. They will like you for that. And then actually look at the goal. Did the client walk down the hall without pain? Did they keep their pain less than 3? Were they able to go back to work? And does that match up with, you know, what they say matches up with what you see? It's something you want to see. And then just as a last little bit, we're going to take a short break here. And then just think about this. Seizure medicines, I don't know if you've learned about these, they're very, very addictive medicines. Very bad side effects. But if somebody just had like a couple seizures a day, would you tell them not to take any? Because it's very addictive. Very addictive medicine. What if they get addicted? They're not getting addicted, they're getting dependent, right? So you would not withhold seizure medicine because they have just a little seizures. You would give it to them because they need it. If they have just a little infection, not terrible infection, just a little like MRSA, but not really bad, just in one arm. But you don't really want to give them antibiotics because, you know, I don't know, it's not really a bad infection. You wouldn't withhold that shit, right? You would not do that. So why would you do that with pain medicine? Say, oh, you told me a little pain, you don't need any medicine. You just give them the medicine. So don't get into that whole trap. It's really a big trap. And you will see so many good, otherwise really good nurses and physicians that really do think that way. That you'd be amazed. And it's gonna be kind of up to you to change that. So you're gonna have to put in your